So I would have several pieces of advice for a surgeon that's new to the MIS TLIF technique. First, it's important to place the stereotactic reference frame contralateral to the side from which you perform your TLIF. This will ensure that it's out of the way and not disrupted during the procedure. Next, I start with placement of my contralateral screws. Again, this is where less of the work is going to be performed, and I want to get those screws in position at the beginning of the procedure. My next piece of advice would be, prior to placement of those contralateral screws, to use the navigated stealth Midas drill to decorticate that contralateral facet joint, as well as the inferior and superior articular process and the transverse processes. This will allow you to pack bone at the end of the procedure and achieve a robust posterior and posterolateral arthrodesis. Once the pedicle screws are placed on the ipsilateral side, I make sure that those screws are placed in such a way that the screw trajectories are less divergent and more parallel. This allows you to have adequate access to the facet joint as well as the disc space on that level. It is important when placing screws on the TLIF side of the operation that you're cognizant of that screw trajectory, as the tulip head will in some ways limit your view of the disc space and facet joint. By placing these screws in a parallel trajectory as opposed to a divergent trajectory, this allows adequate visualization of that ipsilateral facet as well as the disc space, lamina, and central canal. When performing a contralateral or complete central decompression, I ensure that my medial blade is placed along the intersection of the lamina and spinous process. This allows visualization down the contralateral lamina and into the contralateral lateral recess. In this way, a contralateral medial facetectomy can be performed, as well as a complete central decompression. The position of the medial blade is critical to allow for the amount of decompression necessary for a given patient. Finally, if a surgeon is looking to achieve compression of the construct at the conclusion of the procedure, one of the ways in which this can very easily and effectively be accomplished is to measure the appropriately sized rod with a caliper and then reduce the rod size by 5 millimeters. This will provide adequate posterior compression of the construct and improve lordosis.